muscle is one topic which is not read after first year. Generally the nerve muscle physiology comes in the basic parts of the physiology, and therefore after first year generally students don't tend to read this topic again, unless of course there is some pathology related to the muscle contraction, or in medicine there may be some genetic disorders related to nerve or muscle. But therefore nevertheless this topic is very commonly asked in the various entrance exams, and it also involves some basic concepts. And therefore let's start the nerve muscle, starting with the nerve section, and I will be mainly focusing on the classification of neurons, classification of nerve fibers, and then the injury to the nerve fibers and Wallerian degeneration and repair of the neuron. So I'll just give you the sample questions which have been asked in the recent past in various entrance exams. For instance, postganglionic parasympathetic neuron or postganglionic parasympathetic nerve fiber is what type of nerve fiber or what type of neuron? The options are multipolar, bipolar, pseudo-unipolar, or anaxonal. Well, the answer is anaxonal. We will see why. Then the other questions, like a person suffers from an injury, let's say motorbike accident, and there was a sharp injury to the nerve. The nerve was injured, or the nerve trunk was transected completely. What will be the first change in that nerve trunk after the transection, after the nerve has been cut through and through? The options are chromatolysis, axonal degeneration, myelin degeneration, or Schwann cell proliferation. Well, the answer is chromatolysis. We will see why. So such questions have been asked. Let's start with the neuron, the basic structural and functional unit of the nervous system. And neuron is a terminally differentiated tissue. That's the first point to be noted. No new neurons formed after birth. It's a terminally differentiated tissue. So no new neurons formed after birth. What increases is the number of synapses. We go on learning, and therefore new synapses go on forming throughout life. But neurons number does not increase after birth. Well, there is an exception to this. The exception is olfactory neuron. So let me first put out this fact that no new neurons are formed after birth, with the exception of olfactory neuron. I was wondering why this kind of special capability has been given to olfactory neuron. The logic behind it, and I'm saying the logic, I'm not talking about evolution or embryology, I'm talking plain logic, is that, look, the neuron has a nerve cell body, and the nerve cell bodies of all the neurons are well protected within the body. They are deep inside. So they are not prone to the injury as such. The spinal cord neurons or cortical neurons, with the exception of olfactory neuron. The cell bodies for the olfactory neurons, they are located quite superficially, quite on the outside, in the nose, and therefore they are prone to injury. They are prone to degeneration after the injury, with forceful inhalation and exhalation, and with the chemicals that are inhaled. This neuron is prone to injury, and therefore it's a necessity that if the neuron gets injured, it should get replaced. Otherwise, the person will not be able to have the sense of smell throughout life. And therefore, this is the exception. Olfactory neuron continues to divide throughout life. So new neurons do get formed after the injury. Let's see the structure of a neuron. A neuron has a nerve cell body and its extensions all around. So this is a typical neuron. The nerve cell body has the Nissel's granules. Nissel's granules, which have been shown here, which is also called as tigroid substance. Nissel's granules or tigroid substance. Well, because of the tiger-like appearance, tiger spots. The membrane is called as soma. Cell soma. Membrane of the nerve cell body is the cell soma, and these extensions are called as pericardia, a pericardion or pericardia. So smaller extensions on all sides, these are called as dendrites, and there is one long extension on one end which is called as the axon. Where the axon emerges from the nerve cell body, this portion is thickened. So it's called as axon hillock, and just beside that is the initial segment of the axon. This is the structure of a typical neuron. Axon, this is the axonal ending where there is neurotransmitter. It will be released when the impulse arrives down the axon. Okay, so generally speaking, how the impulse transmission occurs from one neuron to the next is that the first neuron generally ends on the dendrite of the next neuron. It's like this. This is the first neuron. Impulse arrives in the first neuron. It makes a synapse over the dendrite of this neuron which we have shown. So neurotransmitter released, and then impulse travels electrotonically. There is electrotonic conduction, direct and passive spread of charges through the dendritic spine. This is the dendritic spine. The charges flow, and through the soma, and finally they will reach the axon hillock. First action potential for this particular neuron, I mean, what is the first point where the action potential is generated? It's the axon hillock. That's the point where action potential will be generated, and then it will be transmitted down this axon. Now basically what I have shown here is the myelinated axon. So impulse transmission occurs by saltatory conduction. That means the nodes of Ranvier, they will generate the action potential, and from one node to the next, well, let me just remind you that this is a myelinated neuron, as we can see in the diagram. So in the case of a myelinated axon, myelinated nerve fiber, the nodes of Ranvier, they are the points where the myelin sheath is broken. So axonal membrane is exposed. Here the action potentials are generated at the nodes of Ranvier, and from one node to the next, the impulse travels again electrotonically. That is direct spread of charges, means sodium coming in from one node of Ranvier will travel up to the next node, and then next node will generate the action potential. So that's how impulse is transmitted. So remember, axon is the nerve fiber, and there are long nerve fibers or long axons, so that the impulse, the signal is transmitted over a long distance. So that's basically a neuron. Remember, it's the axon which is the nerve fiber. But generally there is no single nerve fiber. There are bundles of nerve fibers. In the periphery they will be called as nerve trunks. And a nerve trunk, let's say a peripheral nerve, is actually a nerve trunk. So it will contain bundles of nerve fibers like this. 3 axons shown here, 3 nerve fibers. This is a bundle of axons which is called as the fascicle. So 3 such bundles have been shown in this particular diagram. 1, 2, 3. These are the fascicles. This is the entire nerve trunk, and each individual nerve fiber is the axon. I'm just pushing the nomenclature just as a revision. In the spinal cord, they will be called as tracts. The ascending tracts, the descending tracts. So fasciculus, tracts, bundles of nerve fibers are also called as funiculus. Bundles of nerve fibers are also called as lemniscus. A bundle of nerve fibers would all. So it's all based on the appearance. Lemniscus means ribbon-like appearance. Right. That's the basic nomenclature that we must understand. This is about the neuron. Now, let's classify the neurons. Most of the neurons, majority of the neurons in the CNS are multipolar neurons. Majority in the cerebral cortex, in the cerebellum, they are multipolar neurons. What is a multipolar neuron? You can see here that there are dendrites all around, and there is one axon, the nerve fiber, which will carry the impulse further. But all these are multiple poles. I mean, all these dendrites can receive impulses from various neurons, and then it can be transmitted into this axon. This is a multipolar neuron, and majority of the neurons in the cortex are like this. But some neurons are bipolar neurons. A bipolar neuron means, let's say this is a typical neuron. A bipolar neuron means there is this one axon on one end, and all these extensions, they will fuse on the other end. They fuse to make another pole on the other end. So one pole and the other pole. Olfactory neuron is a bipolar neuron. There is a bipolar neuron in the retina, rods synapse with the bipolar cell or bipolar neuron. There is one subtype of this which is called as pseudo-unipolar neuron. Pseudo-unipolar, because basically it is bipolar, but it appears to be unipolar. Example, the nerve cells in the dorsal root ganglion outside the spinal cord, those nerve cells are said to be pseudo-unipolar. Why? Because, let's say developmentally, there is a nerve cell body and it has 2 poles to begin with. So this is bipolar. But then these 2 poles, they travel a certain distance and they fuse, or making it to appear as a single pole. But then again they divide. One pole will go to the skin and the other one will go to the spinal cord. So this is the dorsal root ganglion. You must have seen some diagrams which show a typical dorsal root ganglion cell, nerve cell. And so what happens is, this is a sensory neuron actually. It's carrying the impulses from the skin, and then they will be further transmitted into the spinal cord. The signals will go to the cortex eventually. Of course, there will be synapses in that pathway, right? So that's a pseudo unipolar neuron, and I've taken it as a subtype of the bipolar. The next one actually is anaxonal type of neuron. No axon. Look, what is the need for an axon? Axon has got a certain length, and it carries the impulse over a long distance. That's the need, that's the use of an axon. Anaxonal neuron means it does not have axon, which means what? Which means that neuron is not designed to carry impulse over a long distance. So it does not need an axon. It does not need a nerve fiber. Where do you find this neuron? Amacrine cell in the retina. This is involved in a very short circuit, in the retina. The circuit is rod synapses with bipolar cell and then ganglion cell, and the inputs of the rods will be modified by the two cells, horizontal cell and amacrine cell. So a very short circuit, and it does not need an axon. Postganglionic parasympathetic neuron. This is also an anaxonal neuron. At the start I had asked this question. Why is it anaxonal? Because look, if this is a sacral segment of the spinal cord, from here the parasympathetic nerve will arise. This is a preganglionic nerve. It will travel all the way to the organ and end in the ganglion. Ganglion being the relay station here. So ganglion is just outside the organ, or sometimes in the wall of that organ. Which means what? Which means postganglionic neuron or postganglionic nerve that we are discussing here, it's very short. It does not have to carry the impulse over a long distance. It's very short distance to be carried, and therefore it does not need an axon. It does not need a nerve fiber. So remember, preganglionic nerve is long in the case of parasympathetic nerve fibers, and ganglion is located near the organ, and therefore postganglionic nerve, which is ending on the organ, is very short. It doesn't have an axon. It does not have a nerve fiber. That's the classification of neurons. Now coming to the classification of nerve fibers. Nerve fiber means an axon. We have seen that just now. But based on the diameter, the nerve fibers classified, this classification is Erlanger and Gasser classification. It's based on the diameter and therefore the conduction velocity of that axon or that nerve fiber. Look, conduction velocity for an impulse is proportional to the diameter of the nerve fiber. Why is that? It's simply because this nerve fiber having a greater diameter means it will provide less of exoplasmic resistance for the flow of ions. There is an exoplasm within this axon, and when this nerve fiber is excited, sodium and positive charges will come in and they are going to travel. Greater the diameter, lesser will be the resistance for the flow of these ions, and therefore they can travel faster and velocity of impulse transmission will be greater. So diameter, a very important factor that determines the velocity. The other factor is myelination. I'll come to that in just a moment. Let's see the Erlanger and Gasser classification of nerve fibers. based on the diameter, as I mentioned just now, the descending order of diameter and therefore the conduction velocity. Basically, there are three types: A, B and C. And in A, we have four subtypes: A alpha, A beta, A gamma, A delta. And that means we have actually 6 types of nerve fibers. A and B, and of course when I say A, I mean all the 4 types. A and B fibers are myelinated. And the C fiber is unmyelinated or non-myelinated. Let's talk about the myelin as well. Myelin, in the case of peripheral nerves, it's formed by the Schwann cell. And in the case of central nervous system, in the case of CNS nerves, the myelin sheath formation is by the oligodendrocyte or oligodendroglia. What is the difference? The difference is, in the case of CNS nerves, one oligodendrocyte is involved in myelination of multiple axons. Generally, the ratio is said to be about 1:20. So, one oligodendrocyte is involved in the myelination of multiple axons, multiple nerve fibers in various directions. And therefore, when the CNS nerve is injured, repair becomes difficult. When a CNS neuron is injured, after it could be an ischemic injury or any such type of injury, repair is almost impossible because it will need a myelin, and one oligodendrocyte was involved in multiple axonal myelination. Therefore, after the injury, there is no definitive path for a growing sprout to enter. There is no intact neurolemma sheath also found in the case of CNS neurons after the injury, and therefore CNS neurons do not repair. But peripheral nerves, many Schwann cells are involved in the formation of myelin for one nerve. So we can say almost, and this I am saying just for the sake of easy to remember. Here we said 1:20, which is a fact. Here multiple Schwann cells myelinate one axon. So I put it as roughly about 20:1. And therefore peripheral neurons, when they are injured, it is possible that these neurons do get repaired. It's possible. In fact, we all must have experienced this, the peripheral nerve injury, even the mild forms of injury, due to the pressure. Suppose we are sleeping like this with the pressure on the hand and the nerve getting compressed, and it's a mild form of injury, the neurons do get repaired. Even the severe forms of injuries in the peripheral nerves, they are going to repair. So that's the difference between peripheral nerves and the central nerves. The myelin formed by different cells and the myelination format is different. Coming back here, we have said that 2 factors determine the conduction velocity. A, the diameter, B, the myelin. So these are the 2 factors which determine the conduction velocity of a nerve fiber. Myelin increases the resistance of that membrane, nerve membrane. Its resistance increases and therefore charges travel faster. So which one is more important, myelin or diameter? Which one is of greater import? It's the myelin. I mean, remember this, that and this is hypothetical. Okay, let me emphasize, this is hypothetical. Imagine a large diameter fiber but non-myelinated, and another small diameter fiber but myelinated. 2 nerve fibers. Which one will conduct more rapidly? It will be the myelinated one. So remember, myelin is of greater importance so far as the conduction velocity is concerned. Okay, let's just finish this conduction velocity part. In the case of a myelinated nerve fiber, velocity is proportional to the diameter. We've said that, but how much? What is the proportion? It's roughly 6 times the diameter. For instance, A alpha, its diameter is 20 microns. Its conduction velocity is roughly 120 meters per second. Right? So in that sense, I'm saying don't take the units. Don't look at the units. Just take the number. So you'll see roughly it is 6 times. In the case of unmyelinated nerve fiber, what is the proportion? The conduction velocity is proportional to the square root of the diameter. Square root of the diameter in the case of unmyelinated axon. With that in mind, now let us see what all things are carried by these nerve fibers. Where these nerve fibers are located, what do they carry? Okay, A alpha, thickest fiber, fastest conduction velocity, as we have mentioned, 120 meters per second. This is basically meant to carry the proprioceptive impulses. So proprioception carrying fibers are A alpha type. Spinocerebellar tract. Look, muscles, when they start contracting, they send proprioceptive impulses. From those muscles, the impulse come back to spinal cord, and in the spinal cord it ascends up, it goes to the cerebellum. This is a proprioceptive impulse. It's conveying to the cerebellum the joint position, which is changing moment to moment. This is the most rapidly conducting signal in the CNS. A alpha fibers. And motor fiber, alpha motor neuron. Look, the motor neuron that starts from the spinal cord and goes to the muscle, to the extrafusal fibers of the muscle, and it brings about the muscle contraction. Again, a very rapidly conducting fiber. It's A alpha type. A beta, touch and pressure carrying fibers are A beta type. A gamma, gamma motor neuron. Well, when the two words join, it's written like this: gamma motor neuron, or it's joined gamma motor neuron. This neuron goes to the intrafusal fibers of the muscle. This neuron goes to the muscle spindle, which is made up of those intrafusal fibers of the muscle. So what is the job of this gamma motor neuron? To maintain the muscle spindle excitability. Okay, I'll give you an example. When you are striking with the hammer, you are eliciting a, let's say, knee jerk or biceps jerk stretch reflex. And if you don't get that stretch reflex, what do you ask the patient to perform? Gendra 6 maneuver. What does it achieve? It increases the gamma motor neuron discharge to the muscle spindle. The muscle spindle will become more excitable. Why do you want to make muscle spindle more excitable? Because muscle spindle is the receptor for this stretch reflex, knee jerk, biceps jerk, etc. Right? But the point is, gamma motor neuron, it's a motor neuron starting from spinal cord, going to the muscle, but this time to the intrafusal fibers, means to the muscle spindle. A delta, it carries fast pain and temperature. Look, pain is of two types, the acute or fast type of pain, sharp pain. It's carried by A delta type. Then B fibers are the preganglionic autonomic fibers. Whether it's sympathetic or parasympathetic, but preganglionic fibers are B type fibers. And the C fiber type Somatic fiber type, it carries slow pain. As I mentioned, fast pain and slow pain, two varieties. Slow pain is carried by C fiber type. And the autonomic fiber, postganglionic sympathetic. Yes, please correlate. When I talked about the B fiber, I said preganglionic autonomic. Autonomic means sympathetic as well as parasympathetic nerve fibers are B type. But here in the C fiber type, I am saying postganglionic, only sympathetic, not parasympathetic. Why? Come on, now you should be able to correlate, because postganglionic parasympathetic neuron does not have a nerve fiber. It is an anaxonal neuron, isn't it? We saw that some time back. And therefore, postganglionic parasympathetic, it does not have any nerve fiber at all. It's anaxonal. So, postganglionic sympathetic fibers are C fiber types. It's a long nerve fiber, because in the case of sympathetic nerves, let's say from the lumbar segments, the nerve starts, preganglionic nerve starts, it comes out of the spinal cord and ends in the ganglion. Ganglion is located just outside the spinal cord. So that's the preganglionic nerve. And then the postganglionic nerve, sympathetic nerve we are talking about, it starts from there, from the ganglion, and it goes all the way to the organ. So postganglionic nerve is long. It has a long axon, the sympathetic nerve. Right. These were the nerve fiber types. Well, there is a numerical classification as well. Numerical classification of these same nerve fibers. In this, only the sensory fibers will be taken out. Look, we have talked about the sensory as well as motor nerve fibers, okay? But we will take out the sensory fibers from these and we'll classify them, and it will be called as numerical classification. We'll give them numbers. It will be type 1A and then 1B and then type 2, 3 and 4. Type 1A, these are called as primary afferents. What do they carry? They carry proprioceptive impulses from the muscle spindle. There are annulospiral endings at the center of the intrafusal fibers. Then those endings will join and they will form the 1A type or primary afferent. It will carry the length of the muscle to the spinal cord. So it is carrying proprioceptive impulse, length of the muscle. 1B fiber, it starts from the Golgi tendon organ. It detects the tension in the muscle. Muscle tension is detected by 1B and it sends to the spinal cord. Then type 2 is again proprioceptive. It starts from the flower spray endings. There are endings of the nerve fibers which are called as flower spray endings. They are in the intrafusal fibers inside the muscle. So this also is going to carry the length, means proprioceptive impulses starting from the muscle and going back to the spinal cord, and from there going upward to the higher centers. But this type 2 fiber is that starting from the ends of the intrafusal muscle fibers, they send the signals via type 2 sensory nerve fiber, taking the proprioceptive impulses. I'm sure there was no confusion. When I said intrafusal fibers, I was talking about the muscle fibers. They send the signals via type 2 fibers. Here I'm talking about these nerve fibers, just to make sure. Alright, so that's and then type 3, the touch pressure, type 4, pain and temperature. So these are the nerve fiber types. So far we have done classification of neuron, Now we've seen classification of nerve fibers. The next part is injury to the nerve fibers, and then degeneration and regeneration of the nerve fibers. First of all, what are the various types of injuries? Hypoxia can lead to nerve fiber injury. Then pressure can lead to injury. Local anesthetics can depress the conduction through the nerve fibers. That's not an injury. Let me be very clear about it. So, you need to see the susceptibility of various nerve fibers to these various types of agents. Pressure. Most susceptible fiber will be A. Hypoxia. Most susceptible fiber will be B. And local anesthetics, most susceptible fiber is C. So A fiber most susceptible to pressure, B fiber most susceptible to hypoxia, and C fiber most susceptible to local anesthetics. This has always created controversy, because I am sure anesthesia professors, they always teach A delta fibers are most susceptible to action of local anesthetics. This cannot be resolved, because this I am taking from the Ganong or physiology books, whereas the anesthesia, let's say Miller's or some other textbooks, they have given some other table, and therefore this controversy remains unresolved as of now. Anyways, coming to the injury types or grades of injury. Severity of injury. Based on this, we have classification. It's called as Sunderland's classification. It gives us the grades of injury. It tells us about the severity of injury. So, grade 1, mild pressure. Mild pressure on the nerve trunk. Temporary form of injury. Either it could be mild pressure on the nerve trunk itself, or that mild pressure is compressing the blood vessel going into the nerve trunk. So, hypoxia. Let me just write it here. Hypoxia causing the injury to the nerve trunk and the nerve fibers. We are talking about injuries to the nerve fibers, injuries to the nerve trunks. What are the grades? Based on the severity of injury, we have these 5 grades which we will see now, Sunderland's classification. Grade 2 injury means severe and sustained pressure. This will result in grade 2 injury. Grade 3 means axonal transection. Let's see these grades. Let's say this is a peripheral nerve trunk. As we already discussed, the nerve trunk consists of fascicles of nerve fibers, bundles of nerve fibers. I am showing 2 bundles having 3 nerve fibers each. Look, there are these 2 fascicles, 1 and 2. This is the entire nerve trunk. So, grade 3 injury means single axon cut. Single axon is transected. That's grade 3 injury. Grade 4 means the nerve fascicle disrupted. More severe form. So this entire bundle getting disrupted. That's grade 4. And then of course grade 5 will be this. Entire nerve trunk is transected. Grade 5, nerve trunk transection. Right. These are that's the grades of severity of injury to the nerve trunks. I have asked this question at the start of the chapter. I'll just repeat the question and add one more. After a nerve trunk is transected, what will be the first change seen in that nerve trunk? And the options given were chromatolysis, axonal degeneration, myelin degeneration, or Schwann cell proliferation. I will add one more question to this now. The question is, the first change seen in the Wallerian degeneration is, and take same four options: chromatolysis, axonal degeneration, myelin degeneration, and Schwann cell proliferation. Answer is different. And why? We will see that in the next 5 minutes. But before that, let me just also tell you that from the surgical treatment point of view, there is one more classification. It's Seddon's classification. Let me just write it here. Seddon's classification based on the surgical treatment point of view. There are only 3 grades. So pressure related injuries, these first two grades are called as neuropraxia. That's one. Neuropraxia. Then a single axon cut, axonotmesis. I am pronouncing that T in axonotmesis. And the bundles cut will be called as neurotmesis. This is from the treatment point of view. The treatment will differ based on what grade of injury it is. So that's the classification of or rather grades of severity of injury. Let's now see what happens after the injury. Now first thing is Wallerian degeneration. This is named after Augustus Waller. Augustus Waller, who described these changes. Note 2 points. One is, these changes are described after grade 5 injury to the nerve trunk. Okay, so Wallerian degeneration are the changes that are seen after grade 5 injury to the nerve trunk. There should be a transection. And second point is, Wallerian degeneration, it describes the changes that are seen in the distal stump after the transection. 2 points noted. One is, the changes that we describe are generally seen after 5th degree injury. Let's add here. These grade 1, grade 2 are also called as 1st degree, 2nd degree, 3rd degree, that's grade 3, then 4th degree and 5th degree injury. Okay, it's interchangeably called degrees or grades. So 5th degree injury or grade 5 injury will cause Wallerian degeneration. That's first point. And second point is, when we say Wallerian degeneration, it means changes that are seen in the distal stump after the transection. Distal stump. What does that mean? Let's find out. Look, we had just now drawn a nerve trunk. These were the nerve fibers bundled into 2 fascicles. These nerve fibers, these neurons, they have nerve cell bodies, right? So let's just draw it diagrammatically. Nerve cell bodies. Let's say the nerve cell bodies are located here. This is simply a diagrammatic representation for the sake of understanding. Right, so these are the nerve cell bodies. And now this nerve trunk is transected. There you go. Now it is divided into 2 segments. You can see that two segments have happened. The segment that is towards the nerve cell bodies, this is now called as proximal segment. And the other part is called as distal stump or distal segment, which is away from the nerve cell bodies. So two segments have been clearly formed. What did we mention? Wallerian degeneration means changes that happen in the distal stump. They are described as changes of Wallerian degeneration. Okay, please note this point. I'm going to come to those MCQs in a while now. Right. So fifth degree injury has happened. Let's see the chronology of events after the fifth degree injury. First change, 24 to 48 hours. There is chromatolysis. Look, from the chromato you can make out what it is. It's related to the nerve cell body. What happens is the Nizel's granules disappear. They are grounded into a fine dust. The nerve cell imbibes water and it swells up. The nucleus is pushed to the periphery. These changes are collectively called as chromatolysis, and they are seen in 1 to 2 days after the injury. We are talking about the sequence of events after the transaction has happened. So within 1 to 2 days you see chromatolysis. This chromatolysis is seen as a preparation for repair that is going to happen eventually. Then this is not a change. I'll just add it here. Up to 3 days, the distal stump is functional. Look, what is going to happen is the distal stump means these nerve fibers are now going to lose their function. They are going to die out and they will be replaced with new nerve fibers, because obviously they have been separated from their nerve cell bodies. And therefore, see, nerve fibers are critically dependent on the nerve cell bodies for their nutrition, other material. So now they are separated, they are going to die out. So that part is where we are looking at when we say Wallerian degeneration. Right. So up to 3 days, they are retaining their function, these nerve fibers in the distal stump. Then by 6th day, 3 to 6 days after the injury, you will see this change. By 6th day, this change will be completed. What is it? There will be axonal degeneration. Let's try to understand diagrammatically. Here are these nerve fibers with their myelin. I have shown only one. All of these are myelinated, okay, but I have shown only one. What will happen is the axis cylinder will break. I've shown it with this cross sign. The axis cylinder will break into pieces and there will be axonal degeneration. The axon will degenerate completely. By 10th day, means 6th day to 10th day, you will see this change happening. It will be completed by 10th day. There will be myelin degeneration. Axon had already broken up and it's degenerated. Now the myelin also will degenerate. So what will happen? Now the distal stump will be empty. Right? Axon gone, myelin gone. By 10th day, you will see oil droplets in that empty tube. Why oil droplets? Do you remember? Myelin is a lipid-rich structure. It's lipid-rich. So, as all the myelin is degenerated completely, but there will be some oil droplets visible somewhere. Right. Repair. Now the repair will start by 15th day. And you will see two changes that happen simultaneously. There will be Schwann cell proliferation from the distal end, from that end. Schwann cell proliferation. Look, we are talking about the peripheral nerve, and here the myelin is by Schwann cell. So Schwann cell proliferation from the distal end and sprouting from the proximal end. A sprout will form like this. That's called as sprouting. So sprouting and Schwann cell proliferation. So what's going to happen now is this sprout will elongate. Gradually, slowly it will elongate. And these Schwann cells will go on wrapping around that axon to form the myelin. And eventually that axon will again go to its original synapse where it was. And the repair will be completed by 80th day. Complete repair happens 80 days after the transection. We are talking about 5th degree injury and complete transection of the nerve. You know, if more than a certain distance is separating the two stumps, then surgically it will have to be sutured. But otherwise, these are the degenerative changes that can be seen, and repair occurs by 80th day. And when repair happens, the axon, the new axon which is formed, it will reach only 80% of the original diameter of that nerve fiber or that axon. It will not reach complete same diameter again. These are the changes that happen. Let's now come back and take those two MCQs. First change seen after a nerve trunk is transected. Look at this and tell me the answer. Chromatolysis? No worries. That's the answer. First change seen in the Wallerian degeneration is, the answer would be axonal degeneration. Why not chromatolysis this time? Recall the definition of Wallerian degeneration. The degenerative changes or the changes that are seen in the distal stump, distal segment after the transection. Those are collectively called as Wallerian degeneration. And chromatolysis is happening where? In the nerve cell body, in the proximal segment. So technically speaking, you cannot, or why technically? You cannot include changes in the nerve cell body in the Wallerian degeneration. Okay. And therefore, if the question is on Wallerian degeneration, first change seen has to be axonal degeneration. But first change seen in the nerve trunk entirely after the transection, then it's the first change, that's chromatolysis. So these are the changes after the injury, the degenerative changes and repair. That was a short segment of the nerve.